Good day, everyone. My name is Cassie Duffin, and today I'll be presenting an analytical overview of the U.S. healthcare reimbursement system. In this presentation, we'll evaluate whether our reimbursement structure truly supports three essential goals: quality, access, and long-term sustainability of care. My goal is to approach this through an evidence-based, data-driven, and policy-grounded lens, much like healthcare administrators do when designing or analyzing payment systems. We'll follow a structured approach. First, I'll give a brief historical background, then move through 6 focus areas that influence the effectiveness of reimbursement today: access, quality, cost, technology, policy, and ethics. Each section integrates current data from CMS, AHRQ, and peer-reviewed studies, as well as insights from the American Hospital Association and Commonwealth Fund. We'll conclude with recommendations for healthcare administrators and key takeaways. Every healthcare leader faces what's known as the iron triangle of healthcare: balancing quality, access, and cost. Reimbursement models sit at the heart of this triangle because they determine how providers are paid, which in turn affects patient access and care quality. The big question we'll examine is whether our current reimbursement models help maintain this. The story of the U.S. in reimbursement is one of constant evolution. After World War II, employer-sponsored insurance became the dominant model. In 1965, Medicare and Medicaid created the first nationwide payment systems, expanding access for seniors and low-income populations. In 1983, Medicare's diagnosis-related groups, or DRGs, shifted inpatient reimbursement from cost-based to prospective payment, incentivizing hospitals and to control length of stay and cost per case. The 1990s brought managed care, followed by the Affordable Care Act in 2010, which introduced accountable care organizations, or ACOs, bundled payment systems, and the beginnings of value-based purchasing. Today's models reflect a continuing shift from volume to value, rewarding outcomes instead of procedures. Understanding how these models actually function is crucial for administrators. Fee-for-service remains the most common. It reimburses each procedure or visit, which encourages productivity, but often leads to overutilization. Bundled payments provide a single payment for an episode of care, for example, a hip replacement, to encourage coordination across providers. Accountable care organizations, or ACOs, go a step further, holding providers accountable for total cost and quality of a population, with shared savings opportunities if they meet benchmarks. Each model distributes financial risk differently between payers and providers, shaping decisions about staffing, technology investments, and patient outreach. For administrators, the challenge is to balance risk exposure with opportunity while maintaining compliance and data accuracy. Reimbursement directly affects who can actually obtain care. Low Medicaid reimbursement rates, for example, discourage provider participation, leading to shortages in rural and underserved communities. According to CMS data, about 70 million Americans rely on Medicaid, yet many live in counties with limited provider access. Telehealth has expanded access since the pandemic, but broadband and equipment disparities mean not all populations benefit equally. For administrators, aligning financial incentives like telehealth parity and rural sustainability payments is essential to maintaining access for vulnerable populations. The Affordable Care Act significantly expanded insurance coverage. More than 20 million Americans gain health insurance, many through Medicaid expansion, but coverage doesn't always equal access. High deductibles and limited networks still deter people from seeking care. Even insured patients often postpone visits due to out-of-pocket costs. Policymakers are now focusing on benefit design, improving cost-sharing rules, expanding preventative coverage, and enforcing payment parity for telehealth to ensure that being insured actually translates to receiving care. This chart highlights how U.S. healthcare is financed. Private insurance remains the largest payer, covering about 29% of total spending. Medicare and Medicaid together represent over 40%. Out-of-pocket spending, about 13%, shows how much financial responsibility still rests on individuals. This fragmented funding structure means cost pressures are shared among all stakeholders. True cost effectiveness requires alignment. Government programs, private insurers, and patients must all be incentivized toward prevention and value. Without that alignment, spending will continue to grow faster than GDP, threatening long-term sustainability. Reimbursement reform increasingly depends on digital infrastructure. Electronic health records, or EHRs, analytics platforms, and interoperability standards like FHIR form the backbone of value-based care. Administrators need accurate, real-time data to report performance and track quality metrics, but compliance and cybersecurity requirements add cost and complexity, especially for smaller facilities. To make value-based care sustainable, reimbursement policy must fund health IT capacity and provide technical assistance for data integration. Programs such as the Hospital Readmissions Reduction Program, HRRP, and bundled payment initiatives show that tying reimbursement to outcomes can improve care coordination and reduce unnecessary variation. However, penalties may unintentionally harm hospitals that serve vulnerable populations if risk adjustment is inadequate. Research from AHRQ and Commonwealth Fund indicates modest but measurable improvements in readmission rates and care quality, though financial savings have been inconsistent. The takeaway is that incentives work best when paired with strong risk adjustment and support for high-need hospitals. Every reimbursement model carries ethical and regulatory implications. Administrators must ensure financial sustainability without compromising patient welfare. Compliance frameworks such as HIPAA, the Stark Law, and the Anti-Kickback Statute safeguard transparency and prevent conflicts of interest. However, as payment systems grow more complex, so do the risks, from data breaches to fraudulent billing or gaming of incentive metrics. This makes internal auditing, compliance training, and ethical leadership essential components of reimbursement management. Reimbursement reform is not a single event, but an ongoing process. CMS continues to test and expand models through the Innovation Center, such as the AHEAD model, which pilots state-based global budgets for hospitals. Looking at 2025 and beyond, new CPT codes for AI-assisted diagnostics and remote patient monitoring signal a shift towards integrating technology into payment structures. The long-term goal is multi-payer alignment, a system where Medicare, Medicaid, and private payers use consistent, quality metrics and incentives that reward outcomes instead of volume. The evidence base on reimbursement reform is strong, but nuanced. A 2024 Commonwealth Fund report found that only 6 of 50 CMS Innovation Center models achieved statistically significant cost savings, yet nearly all demonstrated quality improvements. Studies by De Silva and Zorinsky show that value-based programs improve coordination and safety culture, but financial outcomes are modest without broad participation. This tells us that while the framework is effective for quality, its full financial impact requires scaling and collaboration across multiple payers. When we analyze current reforms, several themes emerge. First, progress is real. Readmissions are down, preventative care has improved, and interoperability is advancing. Yet, administrative burden and complexity remain high. Similar providers often lack the data infrastructure to compete in value-based models, and inconsistent payer rules increase overhead. To achieve sustainability, we need stronger coordination, standardized data reporting, and equity-based risk adjustment to protect safety net hospitals. Emerging technologies, including AI-driven utilization management, may streamline workflows and reduce waste if implemented responsibly. So, is our reimbursement system effective and safe? The answer is partially. It's more data-driven and patient-centered than ever before, but it still struggles to balance quality, access, and sustainability. Progress is evident in expanded coverage and improved coordination, but fiscal sustainability and equity gaps remain unresolved. Future success depends on coordinated payment reform, investment in digital infrastructure, and ongoing alignment of incentives between payers and providers. Healthcare administrators are the bridge between policy and practice. First, invest in analytics and data governance. These tools enable real-time quality monitoring and financial forecasting. Second, pursue multi-payer partnerships to share risk and reduce administrative duplication. Third, build equity safeguards, ensuring that reimbursement models do not unintentionally disadvantage facilities serving high-need populations. Lastly, support workforce well-being, since provider burnout and turnover directly impact cost and quality performance. If there is one takeaway from this presentation, it's that reimbursement reform is a balancing act. The U.S. system has made strides in expanding coverage and improving certain outcomes, but without deeper fiscal and administrative reforms, these gains could prove unstable. The future will depend on smarter use of data, aligned incentives across all payers, and sustained collaboration among healthcare leaders and policymakers. To summarize, the U.S. reimbursement system has achieved meaningful progress in expanding access and incentivizing quality improvements. However, cost growth continues to exceed GDP, threatening long-term sustainability. The path forward lies in integrating reimbursement reform with digital innovation, payer alignment, and accountability frameworks grounded in equity. Only through this integration can we truly achieve the triple aim: better care, better health, and lower cost. Thank you all for your time and engagement. The effectiveness of reimbursement reform depends on continued collaboration among healthcare leaders, policymakers, and practitioners. Together, we can shape a sustainable, equitable system that strengthens both patient outcomes and organized viability. Please see the following 2 slides for references to my research.